webinar. This is a great webinar this morning, welcoming everyone to our NCAS webinar series today. We're always happy to have all of you join. We do record, put on our website. So before we start, I'd like to begin by acknowledging the traditional owners of the land on which we meet today, wherever you are, and also like to pay my respect to elders past and present. It's a very important year this year, and it's very meaningful every time we hear the welcome to country. So acknowledgement of country, sorry. So today's webinar, we've got some highlights around the recent conference in Copenhagen, where there was a very strong representation from our NCAS collaborators and investigators. And our first speaker up this morning is going to be Leanne Teoh. For those of you who don't know about Leanne, she's a pharmacist and dentist, did her PhD in antimicrobial stewardship in dentistry. And actually, she turned a few heads at ECCMID. And in fact, it was a very, very well received presentation, lots of discussion afterwards and new interest. And in actual fact, she has been really driving a global recognition of the importance of antimicrobial stewardship in dentistry. So it's wonderful to hear from you this morning. Following that, we're going to be hearing from our some of our others in the team who also had the opportunity to present. And it was just wonderful. There wasn't a large amount of what we would call One Health, a lot of animal stuff at ECCMID. So it was just brilliant to see Ree and Anna in action, presenting posts and talking. Ngan-Ha represented the guidance team and did a brilliant presentation. So you're going to hear from her. And also Courtney, of course. No need to, I don't know, how many things did you present, Court, in the end? You're on mute.
Yeah, across the NCAS and NAPS team, I was first author for 3, but I had my name on 6. So
yeah, she's a bit of a legend.
Big conference.
And congratulations to Court, because she's also received award for her efforts as well. Courtney's also been shortlisted for the Premier's Medical Research Award, which I'm going to be attending next Monday, as well as Sajal Sahar, who was the PhD in the general practice stream. So I'm really feeling very chuffed and proud about our amazing group. So anyway, I'm going to start rambling on and hand over to Leanne.
Thanks so much, Kaz. I'll just share my screen. That's all good?
So just not on presenter mode yet. Yep, perfect.
Is on presenter mode now?
Yep, take it away.
Great, thanks so much. So when we think about chronic conditions, I don't think that teeth often come to mind, but in fact, oral diseases, primarily tooth decay and gum disease, are the most common chronic condition worldwide. The World Health Organization recently released their Global Oral Health Status Report back in World Antimicrobial Awareness Week last year. And oral diseases affect around 3.5 billion people. And these conditions, so primarily holes in teeth and gum disease, can lead to tooth infections, where antibiotics are sometimes needed, but in most cases, they're generally not required. So in light of the prevalence of oral health conditions, it's wonderful to be here today to talk about the importance of access to oral health care, the role of antibiotics, and the various ways in which dentists and dental teams can then tackle antibiotic resistance in the context of dentistry. So in today's session, I'll be talking about the role of antibiotics in dentistry, what dentists prescribe, and when antibiotics are actually needed. Then I'll move on to talk about inappropriate dental antibiotic prescribing and various reasons, the complexity of prescribing decisions in dental practice. And then, of course, finishing up with various ways in which dentists and dental teams can then address the global public health problem of antibiotic resistance. So role of antibiotics in dentistry first. And where better to start than with teeth. And so these holes in teeth is what myself as a dentist, we see and do all the time. Drilling and filling is like our bread and butter. So in that cavity of the tooth, the outer shell, the enamel is hard, but in the inside, that brown stuff is all soft and sort of leathery. And you can just scrape it away. And in that brown mush is bacteria. And as that cavity gets larger and larger, the bacteria get closer and into the nerve, they battle it out, and then the nerve dies. Unfortunately, the nerve never wins. And sometimes a nerve can die with no pain. Sometimes it can die with a lot of pain, and people can have a lot of pain overnight, keeps them awake all night. They get to us the next day after having not slept, and often there's some degree of anxiety. I was sort of joking before that a lot of people, and it's not a joke actually, a lot of people are quite anxious and don't particularly like dental procedures naturally. And we tell them, actually, you don't need antibiotics for your tooth infection, you need to have dental treatment. And the dental treatment would be a root canal treatment where we open the top of that tooth and expose the necrotic nerve and expose all that anaerobic bacteria to some oxygen, stick some files down the tooth roots, or we remove the tooth. And either procedure addresses the actual source of the infection, which is inside that root canal. And the key message here is that antibiotics are not required for localized infections. Dentistry is all about dental treatment and not drugs. But of course, if an infection hasn't been managed effectively and then spreads, and someone ends up with a spreading infection of their primary or secondary space, like in the photo, that's when antibiotics are needed. They're needed urgently. So this will be from that swelling of the neck will be from a lower tooth infection, and an upper tooth infection generally tends to spread to the buccal or the canine space, then up to the eye. And these situations, we need dental treatment to address the cause, but we also need antibiotics and need them to work. The first infections, orofacial infections that did not respond to penicillin were first documented in the early 80s. There are 5 cases of ineffective penicillin therapy for orofacial infections documented by von Kono. And each of these cases, the species Bacteriophages producing beta-lactamase was isolated, and it was thought that that was the reason for the ineffective penicillin treatment. Penicillin resistance, or antibiotic resistance, of course, does change between place and time. And in Australia, where we are, of course, we have around 11% of severe tooth infections resistant to penicillin in the South Australian population, and about 13% resistant to multiple antibiotics. And these penicillin-resistant tooth infections were associated with poorer clinical outcomes, longer hospital stays, and higher rates of non-response to initial surgical therapy. So antibiotic resistance is, like in all medicine and health, is incredibly important in the context of dentistry. In terms of what dentists prescribe and what antibiotics are normally prescribed by dentists, we did a cross-sectional study published a couple of years ago now. We looked at antibiotic prescribing choices in 2017 in 4 locations, as you can see from the article. So Australia, England, US, and British Columbia in Canada. If you look at the first graph, the colourful one, that is, with the black bars at the bottom, the black bars, they're the prescribing choices. So in the black is amoxicillin. So that's the most commonly prescribed antibiotic in all those 4 locations. And it is in most places around the world, but not everywhere. In Scandinavia, for example, their first choice is phenoxymethylpenicillin in dentistry. In Japan, it's cephalosporins. When it comes to second most commonly prescribed, that's when things differ a little bit. For United States and British Columbia, in that green colour, as you can see predominantly, that's actually clindamycin. And dentists in these areas, but particularly US, are relatively quite high prescribers of clindamycin actually. And that's because that's what's listed in their guidelines for patients who report an allergy to penicillin. We have clindamycin prescribing in Australia here as well. But as you can see in the first bar in Australia with the grey, that's amoxicillin with clavulanic acid. Australian dentists really do like, relatively compared to the other locations, the broad spectrum antibiotic combination product of amoxicillin with clavulanic acid. And in England, it's metronidazole in blue. Again, that's because in their guidelines, that's what's recommended for patients who report an allergy to penicillin. In terms of prescribing rates, they're a little bit different as well, and that's significant, with dentists in the US and British Columbia prescribing around twice that compared to dentists in Australia, and dentists in England prescribing around 1.6 times as much compared to dentists here. And that's significant because the oral health of the citizens in each of these 4 locations are considered to be relatively similar when you're looking at well-established epidemiological measures of oral health, such as rates of tooth decay, proportions of tooth decay, rates of edentulousness, people who have no teeth, as well as access to oral health services. despite the access and provision of the health systems in which oral health services are provided being quite different, the rates of access are considered to be relatively similar, but the rates of prescribing, as you can see, are quite different. So given that dentistry is all about dental treatment and not drugs, there's very limited need for antibiotics in dental practice. We predominantly don't see those spreading infections. Localized infections is what we see most of the time. We'll now talk about inappropriate dental antibiotic prescribing and choices in that regard. So despite the fact that there's very limited need for antibiotics in dental practice, dental antibiotic prescribing worldwide actually accounts for 10% of all prescribed antibiotics, which I think is fairly high given the limited need of antibiotics in dentistry, and the fact that 10% is about same as hospital prescribing in some countries. And so, unsurprisingly, up to 80% of antibiotics prescribed in dentistry are actually unnecessary or inappropriate. And this is for both therapeutic as well as prophylactic reasons, depending on where you are in the world. So, for example, in Australia, around 1 in 2 antibiotics are necessary for therapeutic reasons. In the US, there's very high prescribing for prophylaxis. About 80% of antibiotics are prescribed for prophylaxis inappropriately. And that, to my understanding, is mostly due to prescribing for joint replacements, which are no longer necessary. In the UK, the National Institute of Care Excellence guidelines are very different to the rest of the world and pretty much indicate there's no prescribing there's no indication for prophylaxis in dentistry. So there's very little prescribing for prophylaxis in the UK, but up to 80% are overprescribed for therapeutic reasons, for very different reasons. And most of this overprescribing is because dentists tend to prescribe antibiotics for localized infections where dental treatment alone would be sufficient. However, prescribing decisions are complex, and there's lots of other reasons why dentists prescribe antibiotics as well. So we did a survey of dentists a couple of years ago, and we found that around 77% of Australian dentists will prescribe antibiotics routinely or occasionally if they're running late. Time pressure is a really big factor. A lot of community dental practices, at least in Australia, they're essentially small businesses. And so being able to sort of see people on time is certainly a really big factor for dentists. Up to 82% of dentists will encounter patients who expect or request antibiotics instead of treatment. Not that they would necessarily prescribe, but patient expectations is certainly a very common factor that can influence antibiotic prescription. And 67% of dentists will prescribe antibiotics routinely or occasionally if they're unsure of a diagnosis, but it sounds like an infection. There's lots of non-clinical reasons that influence antibiotic prescription, but this is not just limited to Australian dentists. This is quite uniform to dentists around the world. And so I've got some other statistics up here, so I'm not just representing Australian dentists here. Many surveys to varying degrees show that these factors are at play. So, for example, about a third of US endodontists who are root canal specialists will prescribe antibiotics because of patient expectations. 39% of Swiss dentists would prescribe occasionally if they're not sure of the diagnosis. My colleague Untitled Chapter in Wales did a cross-sectional study and showed these are the odds ratios of patients who would receive an antibiotic at a dental practice, even if no infection is present. So people would be prescribed an antibiotic in the absence of infection. They're the chances of getting an antibiotic. So taking out the infection out of the equation, these are the factors that really do influence antibiotic prescribing in dentistry. So given that there's very limited need for antibiotics in dentistry, but up to 80% are overprescribed with many complex reasons and multifactorial reasons for antibiotic prescription, we'll now move on to the ways in which dentists and dental teams can address the issue of antibiotic resistance in dentistry and, of course, more appropriate prescribing. The FDI World Dental Federation have done a lot of work in this space in alerting dentists and dental teams about the issues with antibiotic resistance and the role that dentistry can play. Obviously, antibiotic use resistance and stewardship is not new at all in medicine, but it's a relatively new concept for dentistry to be able to realise that they really do have a role in this area. And most of these, all these initiatives by FDI have been led by Dr. Wendy Thompson from the University of Manchester and Dr. Paola Anabalon Cordova from FDI in Geneva. And so the first one I want to talk about, I'll talk about some of these initiatives. The first one I want to talk about is the white paper, which provides the central role of the dental team. And it really provides a great overview about antibiotic use and resistance in the context of dentistry and the ways in which dentists can tackle antibiotic resistance. I'll go into that in a little bit more detail in a moment. The massive online open course is essentially the white paper in a more accessible format. And I remember we produced that during lockdowns in COVID in 2020. And it's been accessed by over 2,400 people from over 100 countries worldwide, which is fantastic. It was produced in conjunction with FutureLearn, as well as the British Society of Antimicrobial Chemotherapy. We also have what we call a GARD network, Global Antibiotic Resistance Dental Early Career Researcher Network. And this was also launched in 2020 at a dental research conference. Yes, 2020. And we established this because this area of research in dentistry is a relatively new area of research. We realize that there's not that many of us researching this area. But if we can get together, have a platform to get together with other countries around the world, then it provides a platform for all of us to be able to collaborate and generate ideas and network as well. So our GARD network, we meet once a month. We have a journal club and someone presents their research or what they're working on most recently. And we've had over 20 presentations so far. So the key to that group, I think, is the diversity of the group, actually. We've got people from all walks of research life, I suppose. We've got clinical academic dentists, such as Wendy and myself, researchers in global health, like Paola, ID physicians, pharmacists, researchers in public health as well. So it's a really great network for us to be able to collaborate and generate ideas in this space. Some of you may also know from Twitter that FDI had submitted an application for the Antibiotic Guardian Awards last year, with the results which were released a few weeks ago. And the submission was about engaging the global dental profession to help tackle antibiotic resistance. Each of the shortlisted groups were invited to write an article highlighting what they had done in this space. And so FDI talked about some of the initiatives that I've already mentioned, like the GARD network, as well as the massive online open course and the white paper, and some others which I'll mention in a moment. And some of you also may know from Twitter that we're very happy to say we were successful for the Community Collaboration Award this year, which is fantastic. Another initiative led by Wendy Thompson was the International Consensus on a Core Outcome Set. So we realised that there are a growing number of dental antibiotic stewardship interventions being conducted, but they all report slightly different outcomes. So to enable more meaningful comparison between studies with different interventions in different locations, in an ideal world, they should really report the same outcomes. And so to do this, we decided to establish an international consensus and a core outcome set. And so we had an international steering committee that comprised of clinical academic dentists, so Wendy, myself. We had an ID physician, a specialist in core outcome set development, a researcher in global health, and also we had three experts by experience, so patients who had experience of antibiotic resistance in some capacity or were prescribed dental antibiotics. And the International Steering Committee developed a long list of potential outcomes for consideration from prior literature, and also we had additional ones from the group. And those outcomes were then assessed by 3 stakeholder groups. We had academics, clinicians who had an interest in dental antibiotic resistance and stewardship, and as well as patients who had, again, experience with antibiotic resistance in some capacity or prescribed a dental antibiotic themselves. And they assessed the core outcomes in 2 rounds of a Delphi survey and had a 9-point Likert scale. And from there, we developed the core outcome set. And outcomes were considered for inclusion if they were voted in by 70% more of the stakeholder groups, with at least one person from each group. And so I'll just go through really briefly the results of the international consensus, so you get an idea of what was included and what was excluded. We had aimed for 10 in each group, a pragmatic number given the number of people who do research in this area. And we obviously achieved a little bit more than the 10. We had a slight attrition of patients for the completion of round 2, but not really that many. In terms of what was included, I'll just go really through very briefly what outcomes were included. So unsurprisingly, outcomes related to appropriateness of antibiotic use and rates of antibiotic prescribing and appropriateness according to guidelines were all included. These also were the other included outcomes. So adverse effects relating to the actual procedure itself, the need for escalation of care. And interestingly, the only patient-reported measure that was included was the ability to carry on with daily life as normal. And certainly in the context of dentistry, people can have pain after a procedure. They can have, obviously, if they're given antibiotics and not actually receive dental care, that may not necessarily work, and they can still be in pain and need further treatment after that. And certainly in the context of dentistry as well, if you have a tooth extracted, if it's a back tooth and it's not in function, that might not be so much of an issue. But if it's a front tooth, of course, that's going to generally affect a lot of people's ability to carry on with daily life as well. So other things to consider in the context of dentistry. I'll go through just very briefly the outcomes that were not included to get an idea. I'm not going to go through all of them. There was obviously a very long list. So these are the adverse outcomes that were not included, and about complications from a distant site infection. And these are also the patient-reported outcomes that are also not included. And these weren't included because the patients voted them as in, and the other clinicians and academics didn't include them. Actually, they were not included as critical. They're not considered to be critical by any of the 3 stakeholder groups. And finally, cost was also not included. And cost of dental providers was ranked the least, I think, out of all the outcomes from memory. So that was our international consensus, and hopefully that will provide more support for researchers in this space when developing dental antibiotic stewardship interventions in the future. I want to come back to the white paper now and just talk a little bit and finish up with the 3 key messages in the white paper about how dentists and dental teams can tackle antibiotic resistance. They have these 3 key messages, and these are based on the World Health Organization Global Action Plan: awareness raising, stewardship, and of course, infection prevention. So I'll just finish up with talking about these 3 areas and how, in the context of dentistry, this will help address antibiotic resistance. The first one's awareness raising. And so this is really all about education of dentists and dental teams about their role of appropriate prescribing, the issues about antibiotic resistance, and also education of patients as well. It also does involve the inclusion and promotion of inclusion of dentistry in national action plans of antimicrobial resistance at a government level. Dentistry is often left out. It is in the Australian one anyway. In 2021, FDI also managed to secure the pledge of 59 dental associations from around the world to commit to antibiotic stewardship. And so, whether it be quitting smoking or committing to antibiotic stewardship, all change starts with a decision. So this is a really key measure in addressing this issue and getting the support of dental associations around the world. I should say that the countries in blue are the ones that have signed up for this pledge. They're the key areas about awareness raising. The second one is about antibiotic stewardship. And so there have been several studies conducted with the aim to improve antibiotic prescribing in dentistry. And most of these, to my knowledge, are all, not all of them, but most of them are relatively short-lived studies, and most of them are pilot studies as well. And there's nothing implemented on an ongoing basis anywhere that I'm aware of. Because of the complexity of prescribing decisions, that they're multifactorial, there's so many different factors that influence dental antibiotic prescribing and inappropriate dental antibiotic prescribing. Most of these interventions are bundles of interventions that are customized to the context. So we say here's a lot in stewardship, but a bit like a set of dentures, there is no one size fits all. And so these are mostly customized bundles of interventions for that specific context, such as audit and feedback, or guidelines and education, and various combinations of those types of interventions in dental practice. So they're the key messages when it comes to antibiotic stewardship. The third one is infection prevention and control. Now, as a dentist, when I think of infection prevention and infection control, I always think of it as having, ensuring I've got clean, sterilized instruments to put in my patients' mouths. But and that's certainly one aspect that the white paper talks about having obviously appropriate sterilisation procedures in dental practice. The other aspect when we talk about infection prevention is also prevention of oral diseases, so prevention of tooth decay and gum disease. I talked about this at the very beginning, that oral diseases are the most common chronic condition worldwide. They affect around 3.5 billion people from the World Health Organization Global Oral Health Status Report. There's many statistics to reflect how common oral diseases are. One such example is that in Australia, around a third of children have had tooth decay and attended their dentist and had a filling before they'd even met their primary school teacher. Putting the frequency and incidence, or putting the incidence and of oral disease in the context of other conditions. This graph is adapted from, again, the World Health Organization Global Oral Health Status Report. The number of oral diseases is about 1 billion more than 5 of the most common non-communicable diseases combined, as I've shown on the graph. The thing about oral conditions, however, tooth decay and gum disease, which make up the bulk, there are others, but the tooth decay and gum disease are the majority, is that they are entirely preventable. But dentistry is all about dental treatment and not drugs. And so we need access to dental services to be able to do that. The work that dentists around the world do every day, the preventive work, so drilling and filling, cleaning teeth, reminding you to brush your teeth twice a day, all the public health messaging about the effect of sugar on tooth decay is so important when it comes to antibiotic use. Because if we can prevent holes in teeth from developing or getting big and stop gum disease from becoming severe, then there'll be reduced chance of tooth infections and so less need for antibiotics. And so that's why access to dental services for all and inclusion of dentistry as part of universal health coverage, as part of primary health care, is central to the third key message of infection prevention and control. The World Health Organization described that as a scale. So all the way from fluoridated water, fluoridated toothpaste, public health messaging about sugar, brushing teeth twice a day, which all may sound very obvious, but not obvious to everyone. And in fact, it's not even obvious here in Australia. The latest statistic from the Oral Health Tracker is that 53% of Australian adults brush their teeth twice a day. So that's not to say that the 47% brush their teeth more than twice a day, they brush them less than twice a day. So, public health messaging about prevention and oral hygiene is needed everywhere. So it's a scale all the way from that all the way up to actual oral health services and dental care. I'm just going to divert very quickly and talk a little bit about what happens when you do stop access to preventive dental care. And so the COVID-19 pandemic provided a really, I suppose, unique time in dentistry where due to various lockdowns and to try to minimise the movement of the public, there's restriction on any non-urgent dental service and certainly restriction on preventive dental care. And we got data from a couple of areas where this occurred and where antibiotic prescribing in dentistry was tracked. So Wendy Thompson again and her team looked at dental antibiotic prescribing in England, in that first graph. And as you can see from that red line, which was prescribing in 2020 to 2021, when dental practices were closed, they had an increase in the use of antibiotics. The blue line is the previous year. When dental practices reopened, antibiotic prescribing reduced as well. We also looked at dental antibiotic prescribing during the first half of 2020, just for our first nationwide lockdown between March and around May in 2020. And in dentistry, again, we had a severe restriction on preventive dental care to minimise the movement of the public. We had, when we compared prescribing in June, we had an increase in the use of antibiotics overall by 10% in dentistry, and we actually had an increase in the use of the broad spectrum amoxicillin with clavulanic acid by 20%. And so the pandemic and restriction on dental services really provided a unique time where we could track antibiotic use in dentistry when you do restrict preventive dental services, and showed that antibiotic prescribing goes up, which really reinforces the importance of having access to dental services and inclusion of dentistry as part of universal health coverage in order to reduce antibiotic use. And so overall, dental antibiotics represent around 10% of all prescribed antibiotics, but obviously we've got really high rates of inappropriate use of antibiotics of up to 80%. The three key messages by the FDI, World Dental Federation: awareness raising, education of the public, as well as dentists with regards to appropriate antibiotic use is important. Antibiotic stewardship interventions, like a set of dentures, there is no one size fits all. They need to be customized to the context because of the complexity and the multifactorial nature of prescribing decisions. But at the end of the day, there's very limited need of antibiotics in dental practice. Dentistry is all about dental treatment and not drugs. And that's why inclusion of dental care as part of universal health coverage is central to that third key message of infection prevention and control. So these three key messages provide various ways, a significant opportunity for dentists and dental teams to tackle the global public health problem of antibiotic resistance. Thank you very much. I can stop sharing my screen now, actually.
Thanks so much, Leanne.
I have one question just before we go on to our other speakers. So where are we at in Australia, Leanne? Like it's a George, I think it's amazing presentation, really sort of contextualizing where we're at, but where are we at in Australia? Are we in a good position or a bad position?
Well, the good thing about Australia is that we have, as I showed in one of the earlier graphs, that we have relatively less, a lower prescribing rate of antibiotic compared to some other parts of the world, but we still have up to about 55% of antibiotics in dentistry that are overprescribed. And so I do think that antibiotic stewardship interventions really are still needed, and dentists need to, everyone, needs to play their part when it comes to appropriate prescribing in dental practice. Because it is so multifactorial, it is about developing interventions, I think, at different levels. I do think you need public engagement, provider engagement, as well as engagement from dental associations in order to be able to really tackle this issue.
Court, let you take over.
Yeah, no worries. Thanks again, Leanne. So now 5 of us who were recently very lucky to attend a range of conferences over in Europe last month. I've asked everyone just to prepare a slide or two to talk about a presentation that they found quite interesting or something that they took away from those conferences. So first up is we have Ree Scarborough, who is a veterinarian and one of our PhD students with the NCAS under the Melbourne Veterinary School. So take it away, Ree.
Thanks, Court, and thanks, Leanne. Always excellent presentations from you. And I was thinking, oh gosh, if Leanne became a politician, I would totally vote for you and totally vote for universal dental care. You might want to think about a career change. So I attended, well, Anna and I both attended this One Health oral session at ECCMID, and I'll just quickly go through some of the things that I thought were really interesting. This was a study from a woman in Berlin who looked at thousands of hospitalized patients, some of the case control study, some of whom had a multi-drug resistant organism cultured and a bunch that didn't, with the question, is owning a cat or dog a risk factor for getting an MDRO? Interestingly, so the EPI study of the case control showed that there was really no difference between the MDRO positive and MDRO negative people in terms of pet ownership. And then what they did was zoom in on these people who had MDRO organisms and also had pets, and they wanted to see if they could find any proven transmission between the pets and the owners, not without considering the direction. Sorry, this is slightly blurry, but essentially they found almost 400 pairs of pets and owners that both the pets and the owners had MDROs, and they found one match of an E. coli of a particular sequence type. So they swabbed the nose and rectum of the pets and of their and the pet owners, and saw only one whole genome sequence match between a dog and its owner. And I guess one of the main messages is we do not know which way this is going. And that's something that is worth considering, because I think a lot of One Health is focused on what are the animals giving to humans, but you know, there's also the other question of what are the humans giving to the animals. This was also in a similar vein. These people looked at Klebsiella transmission between different ecological niches, and how much transmission was found, I guess, depended a lot on what they considered to be a match, depended on how many SNP differences they were going to tolerate in their analysis. But overall, they decided between all these niches, and you can see they included dogs, pigs, turkeys, seawater, even mollusks, and they said, unsurprisingly, most of the transmission is happening within niches rather than between niches. So you can see the size of those dots, and if they're on that 45-degree angle, that's sort of within niche transmission, and it's pretty much all centering on that. And they found that the human Klebsiella isolates were by far the most likely to carry AMR determinants. So ESBL, carbapenemase, etc., were almost found exclusively in human isolates. So that was an interesting study, I thought. This one I think is cool, because they looked at, so in the UK, there are some drugs that are, in all countries actually, but in the UK, there are some drugs that are used almost exclusively in farms in livestock. These include fluoroquinolone, neomycin, and streptomycin. And so this group decided to look at resistance determinants to those particular antibiotics, which haven't been used in people, to see if that could be used as a way of detecting livestock-derived AMR in people. But they also interestingly looked at dogs, and particularly at dogs that were fed raw meat, which is a kind of trendy thing at the moment, and maybe getting more trendy. But Anna and I think both agree that this is not a great idea. So if you are raw feeding your dog, maybe think about a different way of feeding them, because raw feeding of dogs was strongly associated with excretion of resistant E. coli sequence types, and they carried strong resistance to those farm-specific antimicrobials, streptomycin, etc. And some of the human E. coli's that they cultured from the bloodstream infections had these same farm-specific AMR genes, suggesting that at some point those determinants originated from farmed animals, and that raw-fed dogs could be a potential intermediary. So that's something that I think people should be aware of. This one was a sort of slightly uplifting study about how reversible resistance is. In the UK, in 2018, they stopped using fluoroquinolones, which incidentally have never been used in food-producing animals in Australia, but they were using them in the UK, and they virtually stopped using third-generation cephalosporins like Keftiafur in their cows. And then they looked at what happened over those 3 intervening years in terms of resistance. So there is some good news in calves, at least. The resistance, so the calves are the green bars here. The resistance to third-generation cephalosporins did decrease, but it didn't really change in cows. I can't comment on why that is. I can't remember what the presenter said, but fluoroquinolone resistance, unfortunately, did look like it stayed stable or went up a little bit. So that's a little bit nerve-wracking, I guess. And they hope that we all hope that with time that the fluoroquinolone resistance will also reduce with not using it. They did some genetic work and discovered that this CTX-M ESBL genes were the driver of the reduction in resistance to third-generation cephalosporins, but this AMP-C resistance seemed to be the thing that was sticking around. So that's that one. And I thought I'd quickly touch on my poster, and it was good that Leanne mentioned how much dentists like to use amoxiclav, because they're not alone. Vets also love to use amoxiclav, and we're using it more than any other systemic antimicrobial in dogs and cats. And my poster was about, well, how often is the clavulanate component actually helpful? So we looked at isolates that responded to amoxiclav, but not to amoxicillin on its own. And you can see on the right, sorry, it's really small, but the orange parts of those bars are the isolates that actually showed any usefulness to the clavulanate component. So you can see in dogs, swab isolates, which could be anything, you know, surgical site infections, pyoderma, whatever. 6% of the isolates showed any benefit from adding clavulanate, and 13% of cat isolates. And in urinary tract infections, you can see it's about 11%. But it's certainly we don't need to be using amoxiclav in a third of, you know, making amoxiclav a third of all of our systemic antimicrobial use. And that is my nutshell talk.
Thank you, Ree. I have many questions, but just because of the interest of time, we might move to Anna. But I guess it's more from the vet stream, like how do we communicate that information to the public about feeding your pets raw meat, and that, you know, that transmission between humans and animals. And yeah, so there's a lot of public messaging that needs to be done about it all. Yeah. So thank you.
We're doing our best.
Yeah. And Anna is up next, and Anna is also one of our PhD students with the NCAS in the Melbourne Veterinary School, and also a veterinarian. We can see presenter mode, but with the like what you would normally see, Anna, not the yeah.
Is that working?
So, oh, yep, that's the one. All right, I'll go on mute. Take it away, Anne.
All right. Hi, everyone. So I was attending the International Conference on One Health Antimicrobial Resistance, also with Ree. So that was a really good conference. It was much smaller than ECCMID. I think there was about 100 of us there. And I happened to sit next to an international expert on phage research. So that was really fascinating. I didn't know that much about phage therapy previously. So I thought I would just give a little update on that. So bacteriophages are basically viruses that can infect bacteria, and they're quite species specific and particularly strain specific as well. So Martha Clokie was the expert that I was talking to about phages. So there's actually a lot of uses, and she did a presentation with the context of One Health and how phages could be used across human, animal, and environmental health. So treating or preventing infections. So there have actually been quite a few people across the globe that have been treated successfully with phages. And also there's a lot of research about prevention too. So linking back to Leanne's presentation about dental health, even using phages potentially to prevent the buildup of bacteria that form plaque, and using that to prevent dental disease was just an area of research, not something that's been done yet, but there's a lot of potential there. Also restoring microbiomes after antibiotic treatment, or using phages to prevent the buildup of antimicrobial resistance, potentially in the environment or a hospital or something like that. And also in the case of animals, so phages could be used in the case of potentially an animal population being colonized with a pathogen that's particularly relevant for humans. Phages could be used to remove that from the food chain. So that might also link back to what Ree was talking about with E. coli in animals, if there's a particular strain that's coming through to humans, either by raw meat, which shouldn't be feeding to dogs anyway, but potentially there's a use for phage there as well. In animals, animals could be a good model for humans, just while research is progressing in terms of how we dose phages, how we prescribe them. Animals could be useful for that. Also, in terms of preventing environmental contamination with bacteria, and removing pathogens from sewage. So those were mainly the two ways that phages could be used in the environment. But phages can also be used to detect pathogens. So for some bacteria that might be hard to isolate, it might be possible to look at the phages that target those bacteria and detect the phages instead, which would be an indicator that those bacteria were present in the environment. The other thing that was interesting that I was talking to Martha about was actually about stewardship. So she was quite keen to develop stewardship practices for phages before they become, quite widely used, because resistance can develop to phages. However, because the cost in terms of bacterial fitness is usually quite high, it's less common than resistance developing to antibiotics. And also the fact that there's such a large diversity of phages, it's less of a concern. However, it's still something that we need to take into account, and particularly there are different kinds of phages. So my understanding is that there's phages that will just lyse the bacteria, but there's also lysogenic phages, which potentially they have the ability to integrate the genes, like resistance genes from the bacterial host chromosome. So that could be a risk for transfer of AMR. So there is a need to have stewardship in place, and I think it would be really good to start developing those practices and get that in place before we're using these phages across populations. The other thing I also wanted to mention was about using phages in animals. So I'll talk a little bit about that next. So there was another researcher there, Michaela, who spoke about phages in ETEC infections in pigs. So enterotoxigenic E. coli is a significant cause of post-weaning diarrhea in pigs. And it used to be treated with zinc oxide in Denmark, which is where this research was taking place, but that's actually now been banned. So this group was looking at using phages to treat this post-weaning diarrhea. And what they've actually been doing is just screening lots and lots of phages for those that will particularly target ETEC. But what I was discussing with the researchers about this is that I had concerns that potentially phages would be used to kind of basically move away from focusing on husbandry, like good animal husbandry, biosecurity, and vaccination, and those practices. So I think that's part of phage stewardship, is to make sure that it doesn't just replace those good practices that we've built up, and particularly in Australia that we have really good biosecurity practices. So it's just something that I wanted to flag in terms of using phages in animals. And then finally, for anyone who wanted to know more, there was quite a good review paper just about the use of phages in the UK for clinical therapy, which I thought was interesting, and it also had a really good introduction about phages in general. So that paper is just at the bottom. And also they actually had a showcase just yesterday, which is available on YouTube, I think, if you just look up UK Phage Innovation Showcase. And that was mentioning a lot of just, I guess, research that is in its infancy, but how phages could be used in the future. And at the moment, access is currently difficult for using phages because often it relies on researchers' networks and matching particular phage strains with the bacteria that needs to be treated. But what they're aiming for is to really develop the sustainable, scalable, and equitable phage therapy where the phages are produced in accordance with good manufacturing practices. So yeah, that's just a little rundown on phages that I thought was really interesting, and hope you enjoyed it. Thanks.
Thanks, Anna. I'll get Ngan-Ha to start sharing her screen while we chat, but yeah, like put in the comments as well. It is a great idea, to be more forward thinking, learning from stewardship from AMS and antiviral stewardship and everything, to be starting to plan ahead for phage stewardship too. With all the wonderful people you met, do you think there's any potential collaborations with the vet school and phage therapy? Or Kaz, sorry, you go.
The word phage stewardship has been thrown around a little bit. So there's quite a bit of work being done in phages up in Westmead with John O'Dell, and it has been talked about, phage stewardship. So definitely it's a really, really interesting emerging field, I think.
Yeah.
Yeah.
Thanks, guys. And so next up we have Ngan-Ha. So Ngan-Ha is our lead implementation pharmacist with the guidance group, and she has been very unlucky to be my ECCMID buddy for 2 years now. So we had a wonderful time. So thanks, Ngan-Ha. I'll give you a moment to. Oh, yep, already sharing. Perfect.
Okay, great. Thanks, Court. Yeah, ECCMID itself was a fantastic conference, so we're really lucky to be able to go there. There were lots of highlights, but in the interest of time today, I'll just choose two. Now, the first one was seeing our, hang on, let me just navigate that. Seeing our very own Princess Mary at the conference, and that happened at the start of it, actually. So as part of her portfolio, she's a patron of the WHO. And when she got together with other global leaders in AMS and AMR, they talked about some things that set the conference, set the scene for the conference. And she talked about health being a fundamental human right, and that LMICs and women are particularly disadvantaged, and she gave reasons for those. And then she talked about AMR being recognised as a global health priority, and increasingly the need for political support to drive for change. The first thing she talked about was the WHO Global Health Strategy, which sort of set off a series of events leading to change on AMR. And sort of to summarise what the conference was also going to be about, the important things to address were new drugs and vaccines to combat infections, talking about responsible use of antimicrobials, talking about investing in technical innovations and strengthening surveillance systems, and also needing context-specific interventions. So she talked about ICOHARs being introduced and established in 2018 to partner with low and middle income countries to help co-develop, implement and test AMR solutions. And so the idea of tackling AMR as a global threat, she talked about no one person or country being able to solve challenges alone, and that the WHO was raising awareness and encouraging action from health professionals and the public, and that global leaders should continue to build momentum and take political action. And that message was also reiterated by the Deputy Prime Minister of Denmark, who was there at the time as well. So moving on to my interests at the ECCMID conference, I wanted to just highlight something that was practical and relatable to our hospital AMS teams. So this is Abby Jenkins, who's an advanced practice pharmacist, and she did a time and motion study investigating medicines administration. And in particular, her aim was to reinvigorate her local AMS service and activities, and to engage nurses at the University Hospitals in Birmingham in the UK. And she asked them, how can we get you involved in IV to oral switch? What is most precious to you? And as with busy nurses with lots and lots to do, they said, give us more time. And so she set about measuring the whole process of medicines administration to really look at the differences between how long it takes to administer oral medications versus IV antimicrobials. So we all know that it takes more time, but exactly how much? So what you can see there in the middle is a blue tray, which involves sort of the process involves sanitizing the tray, getting the tray together for medication dilution and reconstitution, and also the labeling process, which adds on sort of the complexity for IV administration. And then on one of the pictures there's also the IV pump, and there's issues around finding an IV pump, finding one that's fully charged, and that also adds to the time. And then the label on the right is something that they also noted that also takes extra time to write and get checked by the second nurse. So the process of IV administration is a bit more complex, involves two nurses at certain stages, and therefore adds up. Interestingly, in the UK, pharmacy technicians can also administer medications as well. So they also included that population when they shadowed the staff. So again, this is just a summary of what the oral and IV antimicrobial administration process looks like. And they timed 140 oral administrations and 87 IV administrations. And what they found was 80 seconds versus 22 minutes and 5 seconds for IV injections and infusions. So that's on average. And so what they found was 20 minutes. It takes about 20 more minutes to administer an IV injection versus compared to an oral administration. And so the conclusion was that for one appropriate IV to oral switch that's given 3 times a day, that could release 1 hour of nursing time each day. So at an organisational level where there's 2,500 beds that are on the EMR system, they had a mean dose of 2,400 doses of IV antibiotics every 24 hours. And they did that over a series of days and a series of weeks and then averaged it out. So roughly there's about 1 injection for every bed that was available. And when they repeated that in 2 other trusts in the UK, they found very similar results. And so for IV to oral switch, the potential is that around 10 to 50% of all of those administrations could potentially switch over. And so locally, they put that number down. 2,400 daily administrations would potentially take 800 hours of nursing time. So 10% of that would work out to be 80 hours. So that's the potential to release at least 80 hours of nursing time each day across the organisation. So that brought a lot of interest to not only the nurses who were really interested in the significant time savings, but also their managers and medical directors as well. And so IV to oral switch can relieve workforce pressures, and which is also a really different and interesting way to talk about AMS and from a different angle. And also because the data is transferable, it's something that could be put in business cases, for AMS as well. So I don't believe we've done a study that's similar in Australia, but that will also be nice to see. So thanks very much.
Thanks, Ngan-Ha. Sorry, Kaz, do you have?
Oh, it just is a very sobering figure. And I think it sort of shows how we need to take a systems approach with stewardship. So it's not just around how we implement our programs in terms of optimizing antimicrobial use, but it's also optimizing systems and taking a whole of systems approach to the cost effectiveness of what we do. So I think that is definitely something that we should be widely promoting. And thank you for all the specs. I realise we're at time, but I think you can see from the breadth of what was presented today, we'll send some communications around that. Please share your experience with our webinar. We'll be doing some social media around it, and we look forward to what do we got next month, Court?
Next month was a focus on regional AMS. So I have 2 AMS pharmacists presenting on local AMS initiatives they've done at their hospitals. So one's about penicillin allergy delabeling, and the other is about antibiotic hard stops. So we'll start promoting that too.
Amazing. Rod, you haven't escaped. We're going to get you back to present, maybe with all your international work that you're doing around implementation. So you're not going to get away from that. So thanks, everyone. Fantastic session today. Have a great day. I'll be sort of 100% next time, hopefully, and enjoy your day.
Bye, everyone.
Bye, everyone. Thank you.